My family is the Meekum family from the place that we now call Bandon, Oregon. And I'm happy to be speaking with you here today as a associate of the Indigenous Determinants of Health Alliance and member of the Global Task Force for Making a Decade of Indigenous Languages.
Hello, my name is A.C. Locklear. I am a citizen of the Lumbee Tribe of North Carolina, and I am the Chief Executive Officer for the National Indian Health Board.
Hello everyone, my name is Alejandro Bermudez del Villar, and I'm the coordinator of the Indigenous Determinants of Health Alliance. Nice being here.
أزوليت مديسما اسمي نو أمينة محرش تمازلت نتمرت نمركش هاي sisters and brothers. I'm Amina. I'm Amazigh from Morocco, and I'm a current member of the Permanent Forum, but member of this amazing family of Ida.
Hello, my name's Jeff Roth. I am the chair of the Indigenous Determinants of Health Alliance. I'm a former member of the UN Permanent Forum on Indigenous Issues. This is my first year off the forum, and so this report was assigned to me in my last year on the forum, the report that I presented this morning in the main session during our this year's session specifically focused on health of Indigenous peoples. So I'll talk a little bit about the report and what we've focused on this year, and then we'll go back and forth. We have some questions and talk a little bit about more local examples of how this really affects our people. This report really brought together several years of work that we've done specifically in Indigenous determinants of health. Indigenous health is not just a sector, it reflects how systems function together. So in 2023, we did our first report for the Permanent Forum, where we introduced the concept of Indigenous determinants of health and the framework specifically, and we defined 33 risk and protective factors that are unique to Indigenous peoples. Those factors specifically affect our health and well-being as Indigenous people. In 2024, we followed that up with a guide for how institutions can apply these rights that we are recognized in our Indigenous Determinants of Health framework, but also provide cultural safety and implement Indigenous Determinants of Health across their systems. And then last year in 2025, we focused specifically and developed a tool to help systems or member countries evaluate how they are meeting expectations around Indigenous determinants of health. So the study brings those three areas together, this year's study, to really think about how we affect systems overall. We know that Indigenous health is not just created in a clinical setting. It comes from relationships that exist, relationships with land, with water, with biodiversity, culture, and governance. And what this means is that it cuts across all of these intrinsically relates these different sectors. Climate, food systems, knowledge, biodiversity, intellectual property rights, and commerce, and culture. We see our Indigenous determinants of health as creating two different guides. One, it's a systems integrator. So it helps us integrate the conversation about Indigenous health across the different systems we see in the UN space. And Indigenous health is also an outcomes indicator. When we see biodiversity loss or we see the environmental degradation, we also see our health indicators of Indigenous peoples greatly affected by that. So this report really focuses on, we want to use this framework, the Indigenous, or we are proposing that this framework to member states in the UN agency be used as this systems integrator as well as an outcome or an evaluation indicator. Currently, systems across the UN are fragmented quite often. Agencies work in silos. They don't work well together. And the policies, although they all affect our health as Indigenous people from a holistic perspective, the policy mechanisms across the UN system don't communicate and don't work together. We see contradictions across sectors quite often, and this harms Indigenous people's well-being. Also, accountability is weakened when we have different systems focusing on different parts of Indigenous health specifically. And if we want to find a way to meaningfully participate across these mechanisms, like the CBD or the WHO or UNFCCC, the burden falls on Indigenous peoples, one, to educate member states and UN agencies about what is happening in other agencies, because they don't bother to do that, but also to actually participate in these mechanisms. We are under-resourced and don't have the ability to actually participate meaningfully across all of these different sectors and systems. We don't see this as creating a new system. We see this as operationalizing a framework that can connect these systems, that can require these agencies to work with us together in coordination and improve meaningful participation of Indigenous peoples. I think I'll stop there. I think that's a good summary of the report, and maybe we can talk about some of the local examples, or maybe Alejandro, did you want to add anything on the report itself that I might have missed? Sir, please.
Do you want me to add about the disconnection?
Yes, please.
Yes, so definitely, I thought that was one of the questions, correct?
Yeah, you want me to ask the question?
Yes,
Okay, ask the
I think that would be great, so that we can have some context.
All right. Can you share a clear example where disconnected decisions created harm and what a coordinated approach would look like instead?
Yes, definitely. And we can talk about traditional medicine. We can think about midwifery, for instance. And so most people would think that that would be worked under WHO or the Pan American Health Organization, but it is connected to so many other agencies, such as food systems. It is connected to herbal systems, to different practices that deal with intellectual property, that deal with climate change, with territory, and then giving birth in their own lands, etc. So that is connected to many other different agencies, including trade or intellectual property. So when we're dealing with traditional medicine, usually it is approached from the health or clinical perspective, but now it is connected to everything. And this is fragmented across the UN system, and there are different decisions taking place in different mechanisms. So we can see how that fragmentation and not being in different spaces for decision makers may impact or will impact Indigenous peoples in different ways. And that makes it very difficult for advocacy of Indigenous leaders at the global level. Thank you. And I know that the Vice Chair Jennifer also had another example with languages. Is that correct?
Oh, sure.
Yes. Thank you.
Yeah. I've just been focused on languages as a student and a teacher of my native language, Milik, and through my work on the steering committee for the Making a Global Decade of Indigenous Languages. I look at the language that we use in our reports and the language that comes out of UN agencies, and more specifically, the United States government agencies and our Indigenous agencies, and our Native nations in the United States and more locally as well. And there is, across the board, a conflation and confusion around Native rights and Indigenous rights and versus stakeholders. And when we're using the term stakeholders, it minimizes our rights and it minimizes our involvement. It minimizes our right to be at the table. And what we say at the Coquel tribe is, if you're not at the table, you're on the menu. And it's so often the case that Native people and Indigenous people are sidelined when we don't have rights that are recognized by people who are working in these departments, even if they are Native people. But we really need to get that understanding clear that there's a difference between stakeholders and rights holders, and where that language applies is really important.
All right, thank you very much. All right, so next question is, what does it mean in practice to treat Indigenous health as a systems level indicator, and how should that change policy?
Yeah, please.
Okay, thank you for the question. I think that actually health is in the middle of our life as Indigenous people, and this reflection through these 4 reports, it's a progressive reflection. How we begin with the first one, and how we arrive to the 4th one. And this is also a kind of disconnection between visions. You know, this is the unilaterality or unique vision of something that we consider as it's the truth, and the vision of Indigenous people. You can, when you speak about your kitchen is also your hospital, so you need to know what you have in your kitchen if you have this pain of this other, and to actually, for example, how to use it as an indicator. You know, everywhere you can see the pains and the sickness that people are suffering from, and you can have an idea about the health of their territories, pollution, climate change, water, the quality of water. You can see if you have high pressure, it's an indicator of the salinity in the water. So if you have low hypothyroid, you know that there is something missing in this. So when our territories, our land is affected, we will be sick. This is something that countries avoid to do. We have no statistic about all the kind of sickness that people are suffering, to say, yes, there is something wrong and we have to do something because it's not healthy. This territory is not healthy because of extractivity, because of a lot of things, and access to traditional medicine. When you lose your plants, you lose your medicine. So this is something very important to do. Actually, if states and also private sector do our university academic work and research, can be this this list, have to do listing to know, and through this listing sickness we can know that if we have access to a sustainable and also a healthy land and resources. This is very important for us, actually. Thank you.
Yes.
Yeah, I think just to add on and to what she was saying is that, you know, when we look at our health outcomes of Indigenous people, it's not an indicator of something that is genetically wrong with Indigenous people. It's an indicator of the systems that have failed us and that weren't created for us. And having, you know, really systems level indicators means those outcomes are telling you about those individual systems and how they're not working connectedly. In the U.S., we often look at our life expectancy. Currently, the life expectancy for American Indians, Alaska Natives is around 7 years less than the average U.S. citizen. It's the lowest of any population across the board. And that's not to say that our people have genetically poor health. It's to say that they are living in spaces and environments, and the policies that are creating those are not made for them. So when we're looking at how to change that on a policy level and using those systems indicators. We've got to think about how housing is impacting that health, how education and access to education is impacting that health, access to language and those other cultural elements are impacting that health. And we see a lot of communities, especially in the U.S., we see our Native Hawaiian relatives who have revitalized the Native Hawaiian language and how that is shown how it's shown to improve health outcomes for Native Hawaiian children as they go through these immersion programs. We see improving housing and incorporating things like the Indigenous Determinants of Health in tribal codes has improved health outcomes, and we hope to see that more and more.
I'm going to pivot a little because I think we touched on it, but would love for someone to talk about the importance of data and how that, like Amina was talking about, if we don't have the data on the indigenous peoples, we can't even measure these systems. So one of you I know can talk about this, but I think talking about access to the data and appropriate data is a great question that I'd love to hear your thoughts on.
You want to say something?
Everyone looks at Jeff.
Okay. Oh yeah, please. Yes.
Sure. I think this is kind of a across the board. There's so many different issues in and around data and understanding the well-being of our communities. I think first and foremost, just the how reliable that data is. American Indians, Alaska Natives, at least in the United States, have some of the highest rates of just misclassification across all health outcome data. Histories and generations of just mistrust in research and academia has really put us in a place where we don't engage in trials and research, and our communities feel very harmed by past research. So we're often left out of a lot of these data collections, whether it's cancer rates, whether it's other indicators of health. And also, there's fear because of the lack of respect of sovereignty and tribal data sovereignty that data will be used in misappropriate ways. It's not used in conjunction with those sovereign nations and those sovereign people. So there's a lot of different issues there. And we can't really fully look at the health of our people outside of that. In the U.S., we saw that really closely during the COVID-19 pandemic. We had tribal nations, sovereign nations who have the right to do surveillance and public health in their communities, not knowing the rates of COVID in their communities, not knowing how to do any interventions because they didn't have any data. It was kept from them. There's no mechanism to allow them to have the data of their own people. And that's something we see across the board for many of our populations. And I don't know if anyone else has it.
Just add a little bit to it. I think we're on the precipice of a very interesting time in just publicly available information right now that exists around our indigenous peoples, especially in the United States. There are so many publicly available data sets that exist that with artificial intelligence can be associated with individual communities. And I really worry that people that potentially have access to that need to understand the protocols that exist and need to exist in working with individual tribes or communities before there's access to that data specifically. So I think this is a huge frontier that we need to think about at the local, regional, national, and international level, specifically about access to data and access to data about our indigenous peoples, and it needs to remain in the control of indigenous peoples specifically. We need to exercise free, prior, and informed consent before these data tools are used as well. And I'm pretty sure I haven't seen that on any of the AI tools that currently exist. Free, prior, informed consent of indigenous people before the data comes up. So I think we need to be really, we're at an interesting time, and I think that I'm no longer on the forum, but I think it would be a great theme for next year's forum to talk specifically about AI and how it's going to be affecting Indigenous peoples globally. I think this is a marker that we really need to try and get out in front of, and especially around our intellectual property as well. Our intellectual property is being documented and loaded, and I think into these systems, and there's a real risk that things get used without, again, consent of Indigenous peoples. So, yeah.
Yeah. And so I would like to talk about some data-related initiative that we have actually in the second study that talks about indigenous methodology to be added to research that agencies are conducting that impact or work with indigenous peoples. And those would be indicators that are related to the health of Mother Earth, sustainability, decolonization, and re-indigenization of culture. And so we're talking about creating data sets and also research methods and collection of data with indicators that are relevant to indigenous peoples. That could be related to spirituality, that could be related to health and language, or health and the environment, etc. So that is actually in our second study. It is reflected here on our fourth study in terms of systems integration as well as outcomes indicators. So I think that is also a very important shift that we want to see when data is being collected and research methods are being applied for indigenous peoples. There should be relevant indicators.
Just really quickly, I wanted to add to that. I think that's a very important point to also address aggregation of data. And when Indigenous people decide what data is collected and how it's collected, we can decide how it's aggregated. And that to go off of AC's comment as well, and like how it affects the health outcomes. On a lot of forms, we will see, are you, this, or other? And most of the time, our space is to check other. And so then we're put in this, kind of outer space land when it comes to healthcare. Is like, what is other? And I can say from an individual experience that when I went to my first, I guess typical westernized United States, health center midwife appointment, I had checked the box that said Native American Alaska Native because that was my choice. And so my midwife came in and said, "So what was it like growing up in Alaska?" I'm like, I don't know. I grew up in Salem, Oregon. And so even this person who's, highly educated and local to where I live had no idea about what it was like to be a Native nation or what Native nations were. And that affects everything. I did not see that midwife again.
I also think it's important to talk about how that data is presented and interpreted, and being able to do that in consultation and with tribal nations, so it tells the full picture. If you think about it from a Western sense, if a child is raised in a house with a dirt floor, many people think that is not appropriate housing, right? They think it's a poor indicator, when in reality that's how many of our communities live and choose to live culturally because of where they are, or they don't have running water. It's not by choice, it's because of the lack of infrastructure. And those things that we see that come out of a lot of these studies, and we are at a race to the bottom in every outcome measure that exists. And if it's consistently told from that detriment perspective, you lose all the innovation, you lose all the things that really are culturally important to our people. So that's another.
Awesome. Thank you all so much. That really leads us, I think, into our next question when we think about rights to data. So the question is, why is it critical to recognize Indigenous peoples as rights holders and not just stakeholders? And then what will change when we get that right?
You know, in the spirit of giving a local example, I just want to test a little theory and see if the Russian Federation pays attention to our press conference here. But we've seen some objections to our report as it was published on the Permanent Forum website. Specifically, the Russian Federation has objected to paragraph 45 and 44 in our report, where we speak specifically about the rights of indigenous peoples in the Russian Federation. We see new laws that have passed in the Russian Federation. Civil Code of the Russian Federation, Articles 1360 through 1362. And the provisions allow the state to act when access is vital to technologies or medicines, and they deem it to become critical. This means specifically that indigenous people's knowledge cannot be patented specifically, and that the collective rights of indigenous peoples don't exist. So what we're seeing there specifically is that the state and the Russian Federation has said that they have a right to indigenous peoples' traditional knowledge if they determine an economic reason for it or a security reason for it. This has caused a lot of problems with our brothers and sisters that live in Russia specifically. And this is a clear example of how our rights as indigenous peoples are not recognized in a global sense. So that's just one example. I don't know if you guys wanted to add anything else on any other.
Yeah, I think I would like to go back to traditional medicine again. And then, so in different spaces, not only in terms of health or WHO and PAHO, for instance, in the Convention of Biological Diversity or in the Convention of Climate Change, you know, indigenous peoples are put into mechanisms that deal with local populations. And in these mechanisms, sometimes local populations have nothing in relation to indigenous peoples except for sometimes geography. But, you know, so sometimes indigenous peoples and global leaders want to advance on something specific that deals with climate change or biodiversity or the use of herbs or the food systems or their own practices. And then this is not related to local populations. So when the negotiations take place, you know, we get into an impasse, we get into basic installments, or, you know, it gets delayed just because local populations are not supporting what indigenous leaders are trying to accomplish, and because they are not understanding. So it is not that local populations are against indigenous peoples, it's just that the conflation that these mechanisms have forced local populations to be with indigenous peoples, you know, have impacted indigenous peoples by things getting stalled all the time. And this just happened in Panama in regards to Article 8J that talks about traditional medicine, that in reality it should be talking about indigenous traditional knowledge and medicine, but it cannot be called like that because, you know, there's local populations involved in the mechanism. So there's an agency, for instance, the UN Convention to combat desertification. You know, they have created their own caucus. And this is, you know, this is the best way or the best scenario, because that way, you know, whatever global indigenous leaders want to advance, it is not going to be installed or delayed or negotiated with a local population that have nothing to do, and they are forced to be with somebody else. So that would be a good example. Yeah.
So the desertification is the first mechanism we're seeing where they have actually separated indigenous peoples from local communities, and we see that as a real progress. But in these other mechanisms, UNFCCC and CBD, they have combined indigenous peoples with local communities. And I'll say quite often, the advisory groups that are in these large mechanisms are governed by local communities and not indigenous peoples. I've tried to participate as a member of the Permanent Forum in these mechanisms and been told that I don't have a seat at the table as an Indigenous representative from the Americas. I'll give one other issue specifically that has to do with PAHO. The Pan American Health Organization here in the Americas has had long-term a policy that speaks to interculturality. Rather than recognizing Indigenous peoples as rights holders, they recognize Indigenous peoples as stakeholders along with other minority populations that they target with their public health policies. We have told PAHO, and Indigenous communities have told PAHO for decades that this is absolutely inappropriate. And when they adopted the brand new 10-year policy this past year, they included interculturality again, ignoring the recommendations from Indigenous people across the Americas. So institutions, we don't have Indigenous people that work in these institutions, unfortunately. We have non-Indigenous people that believe they know what's best for Indigenous people, and they continue to do the policy that they want to do. This is a pattern that we've also seen in the United States for decades as well. But it's unfortunate that this is we're in the 21st century, and we're still having to deal with these basic issues of understanding the rights that exist for Indigenous peoples.
All right. Next question is, what would it look like to reduce the burden on Indigenous peoples and redesign health systems to be coherent instead of fragmented?
For once, I think, actually creating separate mechanisms for Indigenous peoples, that would create some coherence, because in reality, when Indigenous peoples from across the globe get together, they usually agree, are pretty coherent, the views. So I think just avoiding the conflation of Indigenous peoples, for instance, and let's talk about, for instance, the Food and Agriculture Organization, FAO, they do have a policy, a codified policy for the free, prior, informed consent. And nonetheless, when they are having their food system summit, they are still trying to conflate people, or Indigenous global leaders are getting pressure to work with people that probably are working on vegetarian farming, or nature-based solutions, which they are nature-based solutions, but they are not fully connected with Indigenous knowledge or has the depth. We're talking about One Health as well, and so which is the same thing. It's a good framework that connects environment with animal health and human health, but it doesn't have the depth of Indigenous peoples or the knowledge or the millennia of practices. And so I think just starting by making sure that the conflation doesn't exist would be a first step. And if you allow Indigenous peoples to have their own mechanisms, I'm sure that the coherence is going to be created naturally and in a synergetic way. Yeah.
I can give an example in thinking about reducing burden and just all of those things. One example in the United States is just self-governance, which is an amazing mechanism. Right now, tribal nations in most areas of health, outside of it, whether it's housing, whether it's education, they get a lot of pots of funding from a lot of different places, often in competition with states, localities. They have to pull together 5, 6, 7 different competitive grants to just address one issue in their community. It often leads to fragmented programs that have no real foundation and are often at risk of losing funding at any given time. But through self-governance, which is the mechanism in which tribes can contract or compact and take on those services in a pool of funding. So instead of going grant by grant by grant, they can enter into a relationship with the U.S. government and say, hey, we're going to do it ourselves. Just give us the money. We'll figure out how to do it. We'll figure out the way that works best for our community, still addressing the core principle in which the funding is for. It has worked for years in Interior and for the Indian Health Service, and it is something that we see now, the Indian Health Service, which provides the federal health service for American and Alaska Natives. 85% of their budget is now controlled by tribes and tribal controlled facilities. We are working in the National Indian Health Board and with many partners to expand that across all health and human service programs, so that if there's substance abuse or mental health or other areas of funding that tribes get or receive, they can now start getting that through self-governance, so they're no longer burdened with all these different administrative processes to figure out, and it all just comes together as one.
I can add. So to have an integrated system at the local level is really about looking at the risk and protective factors that we've identified in the Indigenous Determinants of Health, and having our health systems really make sure that they are addressing those systems. So, it's integrating midwives into our healthcare systems. It's integrating traditional practitioners into our healthcare systems. It's making sure that our people have access to traditional practices, to traditional foods and food systems. Those are the ways that we integrate what we're doing into a biomedical clinical setting, and ensuring that Indigenous people are getting a holistic care model for theirs. I don't know if you maybe want to talk a little bit about what you're doing with the tribe and what's been happening there. Yeah. So, okay. Yeah.
Thank you. I'd love to talk about this. So at the Coquille tribe, we have put the healthcare of our people at the forefront by adopting our tribal code ordinance number 146, the Indigenous Determinants of Health Ordinance. And this ensures that at our tribal level that we're looking at and implementing healthcare as defined by the code, Indigenous Determinants of Health. And we're looking at how our operations internally and externally affect the healthcare of our people. And that includes our rights and use of our lands, our waters, our clean air, our language programs, and everything from our natural resources department to the person sitting at the desk at admin. And this allows us to have a lot of freedom of self-determination as well, related to what AC is talking about, and how we act in that relationship with our partners at the Indian Health Services and other agencies at the federal level of the United States. But it also ensures that as people, we're looking at health as number one, as a cross-cutting factor of how we live as people, and that affects the greater community that we're in as well. We're in a rural community, and the way that we conduct ourselves as the second highest employer on the south coast of Oregon in our county area it's a very big deal, that we set that example. And I can read a section from our code here. It refines its vision of Coquille self-determination through multiple holistic initiatives designed to promote a healthy Coquille community, including tribal citizens and families residing on and off the reservation. The ordinance reflects the tribe's commitment to resume responsibility for health of its members and their families, exercising rights to self-determination and self-governance. So not only does it affect how we govern, but everything we do as Coquille people.
Yeah.
Okay.
So I really appreciate seeing what they're doing and how we're doing that. And I'll just mention a little bit, and AC probably knows a lot more about this than I do, but we are just beginning to see the start of the U.S. government at least start to reimburse for traditional healthcare services. This needs to include Indigenous determinants of health, and it's really up to the states on how they're going to be implementing this. We have 4 states right now that have an additional traditional health waiver that's been approved. I believe that's right, 4 states. And so they will be moving into determining how to provide reimbursements through a Medicaid program or insurance for traditional health practices in a clinical setting. So this we hope this holds a lot of promise for ensuring that we start to integrate our indigenous determinants of health into our clinical setting, and we're excited to see how that moves forward. I don't know if you wanted to add anything, but.
And I think it's important to also think about things outside of the traditional clinical setting that impacts health, transportation. We look at our elders and having a ramp added to their home so that they can actually access their home at a certain age, and different things like that. So housing is, for example, that we look at as kind of indicators, but also very important that we incorporate within the system.
Yeah, I was gonna add. I was gonna go back to your comment about integrating midwifery, and in some other countries as well. What midwifery needs is precisely to be recognized and acknowledged as an autonomous health system in itself, right? So rather than absorbing it into a larger, and this happens a lot in Latin America. Rather than absorbing it into a larger biomedical system, midwives need to have their own autonomous system, not only to have midwifery being decriminalized, but just to acknowledge and recognize that giving birth with a pre-partum care, postpartum care, it's part of their right as indigenous peoples, as citizens of that country, to give birth in their own territories with their own practices. And if there is no risk for that partum or the process, they can do it perfectly. I think that is actually backed up by studies from the NIH and also some studies in Europe that giving birth at home, it carries the same risk that if it was in a hospital. And if there is no risk, I think that it is over 80-90% safe. So I think that's something that needs to be accomplished as well, and to provide midwifery the recognition as an autonomous health system, part of the indigenous practices of those peoples.
Thank you.
And financing.
And not only
Finance.
recognizing, but we also need proper remuneration because it is a service for their communities. So I think providing recognition to the authorities, health authorities of their own communities, with remuneration that is compensated accordingly. I think that would be wonderful, and I think that can be accomplished. Our countries have the capacity to do it. We just have to do it in the right way.
Thank you all so much. In considering time, the last thing I'm going to talk about is this is the fourth report and the fourth year. Let's talk about some places that we've seen success with the implementation. You just talked about it with your tribe, but United Nations, World Health Organization. Can we just talk through some places where it has been implemented and what we think has worked well?
Yeah.
Well, we have seen the report specifically outlined and mentioned in the World Health Organization's review of the social determinants of health last year. They gave a separate section specifically to acknowledge indigeneity as a determinant of health, and they went over specifically our 33 indicators that risk and protective factors for indigenous peoples in that document. So that was a huge, I think, win, and for us to have that officially recognized. We have been working with other offices in the WHO and hope to see other reports that we've worked on come out soon. They haven't come out yet, but we do anticipate seeing more of the indigenous determinants of health as part of some of the other mechanisms that come out of the WHO. We've also, in the CBD, the Convention on Biological Diversity, there is a health and biodiversity framework. In that framework, they acknowledge the indigenous determinants of health framework as a tool to use in implementing that health and biodiversity framework. And so that is also giving us an official decision that includes the indigenous determinants of health in it, and a way to have entree into continuing having a conversation with CBD. What am I forgetting?
No, yeah, I just
Yeah.
wanted to mention, yes. Go ahead.
What?
So there are several recommendations on behalf of the forum
Yes.
of the UN Permanent Forum on Indigenous issues that are recommending member states and UN agencies and bodies to adopt Indigenous Determinants of Health as a platform for the recognition and accountability for the rights of indigenous peoples and cultural safety, and as a platform to actually guide agencies to approach indigenous issues or initiatives in a rights-based way and in a cultural safe way. Actually, just last year, there were two recommendations talking about the instrument, because we created an evaluation instrument that is, assessing how institutions are doing in terms of complying with the rights of indigenous peoples as well as cultural safety. So we have several recommendations on behalf of the forum that are instructing or requesting that agencies do it. So we're hoping to actually, the agencies to acknowledge and comply with it. And then it is a process, because we have to educate the agencies on, what they are supposed to do with those recommendations. So we're trying, yeah.
And just a little preview of what my intervention is going to be this afternoon in the main session is to talk specifically about the World Health Assembly's resolution to improve the health and well-being of Indigenous peoples. 3 years ago, there was a World Health Assembly resolution that required a global plan of action to be delivered this year. The WHO has missed that deadline and is asking for another year. I heard the WHO person this morning say that they are going to do it next year. We hope that's the case. And while we've seen the draft of it, and it does make mentions of concepts that are important that we're talking about here, including the Indigenous Determinants of Health and FPIC, there's really no clear way to operationalize these mechanisms for member states or for UN agencies. It seems to be more of a book report on what seems to be important to Indigenous peoples, rather than a framework for how to actually make policy change occur at the local level and at the member state level. So we really are encouraging, and I will be encouraging this afternoon, that the WHO use the Indigenous Determinants of Health framework as the backbone of the global plan of action to ensure accountability across the WHO system, but also across the member states as they work to implement and improve our health overall.
I think one area that we're looking and kind of working to see this more ingrained at a kind of local, national, U.S. level is how tribal nations can evaluate the health of their communities. Most of community health assessments are based in Western kind of public health knowledge and understanding. But the National Indian Health Board, we're working to create a tool in which tribes can measure the health of their community based on the indigenous determinants of health and not solely on those Western metrics, so that tribes can then actually see how the health of their community is related to the things that they find important and is value to their cultural practices, and can use that to then translate to get the resources they need for their communities, and to think about how they are incorporating the indigenous determinants of health in their decision-making processes as they govern, similar to what you're doing.
Yeah. I can say, too, as a tribal leader who is grateful for the work of the National Indian Health Board, that this is the process of integration of the plan and the framework throughout the Native nations in the United States, as one example, is going to have the kind of ripple effect or snowball effect, if you will have, that of raising the bar for healthcare in the United States. I feel that that's going to be one of the outcomes that people are going to look at what we're doing, and they're going to see it as a model, because we know that it's not just Native communities that are suffering from toxins in our waters and displacement from atrocities of climate change or what have you, but our greater communities are going to benefit as well, and that we can show Indigenous peoples as a model of living in relation with our human and non-human people, including like respect for the health of us all. And I feel like this is integral to the survival of our species. But what I can say at the really hyper local level, that we think a lot about gathering together as a previously terminated and a tribe that suffered a lot of assimilation. Half of our people live pretty far away from our homelands, and the adoption of the Indigenous Determinants of Health ordinance has really helped us redefine ourselves, what it means to gather together as people, as a part of our health. And I think that we probably universally experience that lack of availability just to be in spaces that are primarily Indigenous, because of the colonized worlds that most of us really live in. And being able to support that gathering together as a form of healthcare has really changed how we act as well.
That's a beautiful way to close us out, I think. Just reminder, Indigenous Determinant of Health Alliance, all of the reports are available online, so it's indigenousdha.org, O-R-G. You can find all 4-year reports, and thank you so much.